Okay, good afternoon. I realise it's late, so much later than we might have anticipated, so we will keep it brief. But yeah, my name is Kathryn Hart. I'm here with Whyte from the University to give you an overview of a paper that was published earlier this year by a team of people that we are representing. So I'll just go more as we go along. Interest to declare, but we do have a very big team to declare. So we're here representing all of these people. So as you can see, it's across the UK, across Europe, and further abroad, including Sanjay, which is perhaps over here. So the aim of the paper was to review the available evidence and provide recommendations on the optimal management of reproductive health in women who've had prior bariatric surgery. And as I say, it was published earlier this year in Obesity Reviews, it's open access, so I'm obviously only going to be able to give you a very kind of top line today, but it's out there very easy to get if you want to find out more. Again, given what time it is on a Friday afternoon, I'm not going to go into the methods, but just to say that we used this adaptive structure for guideline development, and essentially through a couple of large face-to-face meetings, we came up with a list of clinical questions that we felt needed answering in this sphere, and then searches were done for each of those, and say essentially it was very much a team effort, which you can imagine took some time for some of the questions to come to a consensus, but that was how we did it. So in the paper itself, we actually split the recommendations by stage. So preconception, during pregnancy, and where there is evidence for each of the trimesters, and postnatal, including recommendations for breastfeeding. Again, for today, we're just going to focus on some of the top line topic-based take-home messages, but this slide just gives you a kind of feel, hopefully, for the scope of what's covered in the full guideline has been published. So the different topics and also the different stages at which they're relevant. So, get to the crux of the matter. So, one of the topics we're also very keen to look at was contraception, and in terms of this, we're thinking both about what is the optimal time interval from surgery to conception, and also what is the optimal form of contraception to achieve that time interval. So if you look at the first question first about the time interval, there's this commonly held belief that women should wait 12 to 18 months, but actually that's based on very little hard evidence, and if you really dig down, there's a couple of case reports that came from originally that then it just gets repeated and repeated. There was only 14 papers that we actually uncovered that were kind of any use in trying to address this, and you won't be surprised to know the methodology was quite limited in parts. But essentially, I think what most people would agree is that it's not really about a set time, and that's a bit misleading, this idea that we keep repeating it's 12 to 18 months. What's important is that women have achieved their maximal weight loss, achieved weight stabilisation, and are nutritionally as optimised as possible. That's what's important, not how many months they are post-surgery. And of course that's going to be different for every woman, but what the evidence does say is that on the whole, and this is obviously an average, that tends to be at least 1 year after sleeve or Roux-en-Y, and possibly longer after gastric band. In terms of how we then go on to achieve that time delay, because we know that fertility increases rapidly after surgery, it's really important that contraception is discussed before the surgery, not wait until after. And then obviously the optimal contraception has to be discussed, it has to be prescribed, and it has to be adhered to. And that is a big issue often in this population because many women have long-standing infertility. So it might, however much we talk about it, it's not necessarily on their radar as something that's important. Generally, the advice is to avoid combined oral contraceptive for two main reasons. Firstly, the worries about how well they're going to be absorbed, and secondly, obviously, even with weight loss, a number of these women are still obese, and so those contraceptives would be contraindicated. So we're talking about encouraging long-acting reversible forms such as IUD or implants. In terms of diet, again, very few specific studies have been done in women who are pregnant following bariatric surgery, so we've had to really take the best combination of the general post-surgery advice and our usual conception and pregnancy advice and come up with a sensible guideline. On the whole, it's okay. Obviously, there are some things that don't necessarily match up. But if we're talking about kind of common issues that happen in the pregnancies post-surgery, or symptoms if we can call them that, then the main ones reported tend to be extremes of glucose, which has already been mentioned earlier, or glycemic control, and in some women are more prone to dumping, both early and late dumping. So obviously, on the whole, the same general advice about looking at carbohydrates, so both in terms of the quality and the quantity of the carbohydrate, how it's spaced out during the day, encouraging more protein-rich foods. But actually, I think it's really important to remember that regardless of bariatric history, a large number of women who are pregnant have poor quality diets. So actually, whilst it would be lovely to be able to say, oh yeah, there's this amazing diet that we should recommend, it's not rocket, it's the usual healthy eating. And actually, just reminding people of how important that is just as important. Supplements, again, clearly a big issue. Anyone post-surgery will hopefully be having their supplements, and so again, very little specific evidence around monitoring women in pregnancy with prior bariatric surgery. So the general advice remains that they should continue their post-surgery supplementation through preconception with a multivitamin, multimineral that gives this kind of profile. As been mentioned earlier, the importance of B12, but clearly looking at folate as well. And actually, I think, again, it's been touched on already, what's important is that we're monitoring these people, it's these women. That's what's going to tell us what's needed. But again, there is no magic prescription about the level of nutrients. They vary so massively from patient to patient. So it's really about having a very rigorous monitoring, prescribe, monitor, adapt approach. So obviously the regular monitoring after surgery, as long as people can be engaged in follow-up. For those considering a pregnancy, ideally they should be monitored 3 to 6 monthly. And again, in the paper we specify which things should be monitored more frequently and slightly less frequently based on the evidence that is out there. And obviously, once they are pregnant, at least monitoring their levels of micronutrients, protein, iodine, etc. every trimester, and again supplementing and follow-up monitoring as necessary.
Right, I'll take you over here. So my name is Martin Whyte. I'm a consultant diabetologist and senior lecturer in public medicine at the University of Surrey. Right, so just carrying on here. So there's we also discussed gestational weight gain. How much weight gain is appropriate in a woman in her pregnancy after bariatric surgery? And of course, there's very little evidence. Part of the difficulty here is, as Kathryn was saying, if your pregnancy occurs in the catabolic phase after surgery, you'll be losing weight. So maybe, for instance, in that situation, a relatively stable weight actually represents a degree of weight gain over and above what would be predicted in terms of the previous trajectory. We just don't know. So we've decided in the end, in the absence of evidence really, as to what we should be targeting in these women, pregnant women after surgery. Just to revert back really to the Institute of Medicine guidelines, this is the American body, I think it's now called the Academy of Medicine, whose guidelines are for obese women per se, so not after bariatric surgery. But in those group of women, they are comfortable, if I can put that word, comfortable with a 5 to 9 kilogram weight gain during pregnancy. So we've kind of put that into this set of guidelines with the caveat, as Kathryn was saying, that it's all about measurement. And coming to the final slide is particularly measurement of the fetal growth. So what we're worried about in terms of maternal weight, of course, is if she's too catabolic, you can end up with a small gestational age child, but equally she could put on a lot of weight, but then you end up with difficulty in terms of the actual birth process or issues such as section or indeed macrosomia. So you're going to have to relate the maternal weight gain during pregnancy to how the fetus is going on scanning. But there's a very crude estimate, 5 to 9 kilograms is considered okay. But if you've got a very nicely on a 50th centile fetal growth, but the mother's not putting on weight, you wouldn't necessarily suggest that she has to go on and actually gain that weight just for the sake of it. In terms of breastfeeding, there's a bit more data on this actually. So what Kathryn says that we judge each suggestion as a level of evidence, with level 1 being very good evidence, randomised controlled trials and the like, level 4 being kind of best guess, for want of a better word, level 3 is sort of case reports and so on. So in this particular case, there's a bit more evidence that certainly the macronutrient composition of breast milk does not seem to change after plastic surgery. What there were, though, was a few case reports regarding micronutrient deficiencies in the breast milk in some women. And so really because of that, which is fairly flimsy evidence, the advice in the paper was, well, you're going to have each trimester micronutrient monitoring, as Kathryn's alluded to, during the pregnancy, and it's really to continue that into the 6 month, the advice is to breastfeed 6 months, continue into the breastfeeding stage. But not an awful lot of evidence underpinning that. It's certainly definitely encouraged to breastfeed. I think that's the bottom line. A couple of surgical issues, again, with good quality evidence behind them. I'm not a surgeon, so apologies to my surgical colleagues here, my rudimentary knowledge. There's two main issues to watch out for, and that depends on the type of surgery. So if you've got an adjustable gastric band, that can slip. So if you've got a raised intra-abdominal pressure with the developing baby, that can push against the stomach, and you get slipping of gastric band. So essentially what that means is you kind of get a bit of it's almost like a herniation of you've got more stomach above the band. It's got sort of almost herniated. Again, apologies for explanation this. But you can end up with vomiting. So sort of second, third time of vomiting in these women. Which may entail needing the gastric band be completely deflated, and then consideration about how you deal with that after the pregnancy is finished. The other one in Whyte particularly is internal herniation. So you get herniation of the bowel through the small bowel limb. So during the process of after surgery, you cuts in the fascia that hold the bowel, and in the worst case scenario, you actually get movement of the rest of the bowel through that, causing herniation, and that can be very dangerous. So our surgical colleagues on the panel are very keen to highlight this. So you've got a woman who's got severe abdominal pain during the pregnancy, who's had to be on Whyte. You must consider this internal herniation to put it otherwise to get a surgical opinion. Diabetes, so we didn't talk about treatment of diabetes, that was beyond the scope of this. We were mainly focused on screening for diabetes, so diabetes in pregnancy, gestational diabetes if you like. This generated a bit more sort of discussion. And as you can see, the level of evidence is very poor, so this was kind of best guess, if you like. I think most people are pretty much in agreement that early at booking, you should certainly get an HbA1c and a fasting glucose, and that will identify people with pre-existing type 2 diabetes. I mean, very rarely type 1, but type 2. The problem comes is how do you start screening for gestational diabetes thereafter? And that relates to issues being raised already in the discussion about dumping. Because of course, if you gave an all-glucose load, you can induce this awful syndrome of dumping, which is sweating and feeling faint and indeed hypoglycemia up to 3 hours later. So you have to be very careful. That's not really an issue with gastric banding, but certainly when you've lost your pylorus with real Y, that's a big issue. And it can also happen in sleep restrictions as well. So that's a tricky one. So we thought the best kind of compromise really was to ask these women to do a week of 7-point glucose testing, so pre and post meal, over about a week period, in between 24 and 28 weeks. That's something of a compromise. It's pragmatic in that you can then see whether these women are above our target glucose values, so we aim for less than 5.3 fasting, 7.8 at 1 hour after, and 6.4 at 2 hours after. That's the kind of target. But those aren't diagnostic thresholds for gestational diabetes. So in other words, you couldn't actually truly say that people do have gestational diabetes. It's much more pragmatic. So for instance, there are issues therefore with regards to clinical coding. could we ever say this person has gestational diabetes and how that translates into metadata and so on? So it's tricky. Failing that, we could also consider continuous glucose sensing systems. And lots of people now do actually self-buy these freestyle lever and kind of cost this nice little patch thing that you can swipe. So we're now seeing more and more people coming to clinic with these things anyway, which we don't even ask them to do, but they're self-funding. The key thing there is what's the time interval between eating and the glucose, because you tend to find people swipe, and with no regard to the time interval. So that's some pragmatic guidance. Just one thing on treatment, because I can't help myself as a dermatologist. Often people target the 1 hour glucose as a treatment target in gestational diabetes. Fine, but just to say, you get slightly different glucose profiles in somebody after somebody's surgery. You get a big peak and then later drop. So if you're targeting that 1 hour value, let's say you're going aggressively with tablets or even insulin to get that 1 hour on target, you can overshoot and end up with hypos later. So I would, with a bit of caution with targeting 1 hour treatment diets, you certainly have to factor in the 2 hour value that you're not overdoing. Talking about mental health, again, little data in pregnant women specifically. Ronan Delegates, who was on the panel, has done a study in Belgium, a questionnaire study of pregnant women as whether they had depressive symptoms or anxiety symptoms during the pregnancy. They compared that to obesity controls who hadn't had that surgery. He found there's no difference in risk of depression during the pregnancy. There's slightly higher scores of general anxiety. Okay, so that's just something to say. In terms of postnatal depression, there's no data at all as to whether or not people are greater or lesser risk after having their actual surgery. One thing that certainly comes through, there's a big paper in Western Australia on this, is that if you've got somebody who's had a history of mental health problems before bariatric surgery, after bariatric surgery, it seems to unmask it, and they have a 2 to 3-fold high risk of hospitalisation for that mental health problem. That wasn't specific to pregnancy, however. But based on data like that, certainly if you've got somebody with a past history of mental health problems, I think you need to be on the alert during a pregnancy period that we're in an evidence-free zone there. And so the final slide, yes, on the monitoring is it all comes back to how the baby's doing, of course. So all those things we talked about relate to the mother, but what's the end result of that? So fetal growth is incredibly important. You of course need to look for congenital abnormalities. There's no data, well, there's a few case reports, I should say, that have suggested a higher problem with congenital abnormalities after bariatric surgery, but very little hard data. But really because of that, you certainly advise a detailed fetal anomaly scan in early second trimester. I think the fetal growth is definitely very important because, as I say, there's a higher risk for small gestational weight babies after bariatric surgery. Indeed, if there's a big maternal weight gain, risk of macrosomia. Small babies are also more likely if the mother's a smoker or she's a young mother. And indeed, if the mother isn't gaining too much weight. So in those situations, we definitely recommend a monthly growth scan after fetal viability. And that will help in terms of managing the mother's diet as well as keeping very close track of the baby. To sum up, we also identified a whole range of research gaps because you can see a lot of this evidence isn't level 1 evidence, or even level 2 evidence, a lot of it's 3 and 4. So, huge numbers of areas of interest. What's the optimal timing of pregnancy after bariatric surgery? What are the micronutrient replacements we should be targeting? How do we screen and diagnose gestational diabetes if we can't do a tolerance test? We're very good data about maternal depression after pregnancy and bariatric surgery. So a lot of work that needs to be done. But as Kathryn said, the paper's open access. Look at that. And grants and what I've been able to talk about today. Anything else you want to add? Good, great.
Any questions? I just go back to the breastfeeding comment. So I know but I've definitely had quite a few patients who struggle with it post-surgery, and I wondered whether it's a bit of the research says it's, but the reality is something different. I didn't know if anyone else had any experience.
And which, sorry, when you say
I've
struggle,
been struggling with production and quality of milk, so happen to top up with formula.
yeah, so the problem is there just isn't any. Yeah.
So whether it's a case of they would have had those problems
Yeah,
anyway.
because again,
Or
there's
was it-
this suggestion that it's again harder to breastfeed if you're obese anyway. But again, how much of that is perception versus reality? Because so few studies, and when they do these studies, trying to recruit, because I know someone's trying to do it, trying to recruit obese women or trying to recruit women post-bariatric surgery who want to breastfeed, your numbers go down and down and down. But that's why, I mean, that's the information, you know, if you're seeing that, we need to find a way, you know, as a kind of across the country and further afield of gathering all that information, because this is still a very small population, but it's growing and, you know, it's important. But there is just so few studies out there that we have to find a way of, gathering that information, because if that's what you're seeing in practice, then, you know, we need to address that. You were going to say?
Well, I was just going to add, I work as a breastfeeding supporter as well, sort of as a side, and I think that's just a struggle for everyone. And you know, we have one of the worst rates in the world in the UK. So I wonder if part of that is just preparing people that it's going to be really hard in the same way that everyone should be prepared for that. Because sometimes I think people, when they're struggling as well, if they've got that reason to stop. And that reason might be, well, because I had surgery, I can't make the milk. So,
yeah,
you know,
I think from our point of view, we're saying actually that's not, there is no evidence of that. So not to put more pressure on people, but yet we can at least reassure people that
it's a really
actually
difficult thing.
there's no reason why your milk won't be good enough, but
Yeah,
yet
get
you
the right
support.
support. Yeah.
Absolutely. As you say, it's getting that balance, isn't it? Because
I found the patients the other way. They didn't want to stop, but they felt they were having to stop
Yeah.
because of the lack of milk.